Good evening. I'm Denise Fong, and I represent the University of Toronto Men's Issues Awareness Society. Welcome to our monthly public lecture occurring on the third Thursday of the month at U of T. This is our first event of the 2016-2017 academic year. Our goal at the UTMIAS is exploring gender identity, equality, and responsibility in society as U of T students, alumni, faculty, and university community members, particularly in areas of gender that are understudied in contemporary culture. Our events are sponsored by the Canadian Association for Equality, or CAFE, a registered charity dedicated to an open, evidence-based discussion of gender issues in Canada. Justin will speak on behalf of our sponsor.
Okay, thanks, Denise. You were bending down, but actually these aren't active, so. Oh, you were looking at your notes, okay. Thanks everybody for coming out tonight. I think we're going to get a few more folks streaming in, but because you were all kind enough to show up on time, we're going to get started. First of all, if you haven't, and maybe Andrew could hand these out to those who weren't able to pick one up on your way in. This is just an article, actually one of our members sent us this week, called Why Doctors Don't Talk to Boys and Men About Sex. This was actually published in August, but we thought it was appropriate given the subject matter tonight. So take a look at that. I work at the Center for Men and Families, so I want to tell you a little bit about the programs and services there and some of the other things that the Canadian Association for Equality is up to. CAFE is involved in a variety of different areas, trying to raise awareness about gender equality, men's issues, and men's health. We do that through educational events, sponsoring the University of Toronto Men's Issues events, sponsoring events at a number of other universities across Canada. We're also very involved in various public policy efforts. One of the big ones right now is actually advocating for a gender-inclusive inquiry into missing and murdered Indigenous women and girls. We think all genders should be included in the inquiry. If you look at the statistics, there's good arguments for why that should be the case. It's one example of a pretty big public policy effort that we're working on. We're also very involved in campus outreach, of course at U of T, Ryerson, but also across Canada at a number of other schools. And then, as I mentioned, I manage a very special place called the Center for Men and Families, which is a mental health and social service facility or hub for men and their families. We've got lots of things going on there. There's brochures, the blue ones in particular, that go into the details about the services at the Men's Center. There's the purple brochures that talk more generally about CAFE. And I'll just give a plug for a couple of upcoming events. One is this Sunday, Sunday afternoon, which is our Halloween party. There's a poster right there if it hasn't fallen for it. So I hope to see many of you at that event. You can ask me about that later. And then our next lecture in conjunction with UTMIA, this one I'm very excited about, is with Professor Jess Haynes. She is a professor at the University of Guelph who has done a lot of research. She's been looking at the relationship between father involvement and the health outcomes of children. So a really interesting sort of intersection of some of the different areas that CAFE and the UTMIA find of interest. That's November 17th. I hope to see you there. And the last thing that I will do is invite up Hayden, one of our volunteers, to talk about one of the programs at the center. Go ahead.
Thank you. Hi, I'm Hayden. So Scott and I, two volunteers, are running a kind of men and masculinities discussion group the second and fourth Thursday of every month at the CCMF. So please come out and attend. Thank you.
Okay, and just before I call Denise back up, I just want to thank Orest for making this event a possibility. He will be a sponsor in tonight's event along with CAFE, and Orest has some remarks that he will share about why this particular issue is important to him and what he's doing about it. That will follow Dean's presentation tonight. So thank you both. Denise.
I'd like to also welcome you to, or encourage you to like our Facebook page. It's at UTMIAS handle, and on Insta we are also at UTMIAS. Here on the Facebook page you'll get our notice of upcoming events, including next month's special on fatherhood. Tonight I'm pleased to present you with our dedicated talk on men's sexual health, Breaking the Taboo. Here with us is noted urologist Dr. Dean S. Elterman. He is a faculty member of the Division of Urology at the University of Toronto and is a staff urologist at the University Health Network in Toronto. Dr. Elterman is also the medical director of the Prostate Cancer Rehabilitation Clinic at the UHN. Please welcome Dr. Dean Elterman to the University of Toronto Men's Issues Awareness Society tonight.
Good evening, everyone. It's a pleasure to be here to speak to you about issues around men's health and particularly men's sexual health and sexuality. As I was very nicely introduced, I'm a urologist just across the street almost at the UHN. So I work at Princess Margaret, Toronto Western, Toronto General. And I spend a good half of my time dealing with men's health issues, particularly as it relates to urinary function and sexual function. So men, as they get older, their prostates enlarge, they have a difficult time urinating, they develop prostate cancer, they have difficult times with erections and sexual health, and so I spend a lot of my day discussing these types of issues. So I thought tonight I would bring up a couple issues. I'm used to sort of giving these very sort of academic talks with like lots of stats and talking to other doctors. I'm going to try and keep it very general. There will be some science behind what we're talking about because a lot of what I want to present is evidence-based because I think sometimes our perceptions about myths about sexuality or taboos are couched in old beliefs that don't necessarily have good science behind them. So we'll talk a little bit about that. In terms of an overview tonight, we're going to talk a little bit just about genitalia and men's sort of their equipment. We'll spend most of the time talking about erectile dysfunction because that's really, when you talk about men's sexual health, that's a large part of what men focus on in terms of diagnosing it and treating it, the different types of treatments and some newer types of treatments that are available, some other sorts of sexual dysfunctions. And I'd like just to be able to open it up for discussion. We could have it open in terms of comments, or you could write down questions and pass them to the front at the end. That would be fine. So historically, what's interesting is that even in ancient Egyptian and Greek mythology, there's sort of been this issue of phallocentrism, being that like the penis is very central to a man's identity. And whether or not in this day and age, 2016, that's still relevant could be debated, but certainly a lot of men feel very attached to their penises, and its function is very important. And when you look at sort of cross-cultural obsessions, whether you're in the Amazon in South America, where you're in India, whether it's prehistoric, there are all sorts of customs related to men's genitals. And that really carries forward to sort of some modern day obsessions. A lot of men are concerned about their size of their penis. There's an emphasis on it being bigger. There's some certain stigma and taboo around different sizes of penises, and there's a lot of media influence around the importance of sex. I think with the internet, with pornography, with just general pop culture, sex has become much more prevalent, and as a result of that, a lot of men can feel insecure or really not know what is normal and what is abnormal, and as a result of that have some insecurities. So there's certainly quite a big demand. And it's even now sort of, there's labels coming out, right? So there's syndromes like that used to never exist, but now you can actually sort of be diagnosed with something like a small penis syndrome, which may or not be a real thing. But in fact, a lot of men have body image issues, much like women have body image issues. And I think this is a very relevant thing to bring up in a forum such as this. When you talk about penis size, we typically measure the flaccid state, not the erect state. And there is a wide range you can see of average normal lengths. And you can see, for example, the normal length of a flaccid penis is anywhere from 7 to 13 centimeters. So double the size is still normal. So really, the point is that there are a wide variety of normal variations, and I have a lot of young men and older men coming in to me expressing concerns regarding their genitalia, and I would say that 99% of the time I reassure them because they're entirely normal. So I think that's one concern that a lot of people have, maybe more than historically. Penile curvature is something that often men come in to be concerned about. No penis is perfectly straight. All penises typically curve a little bit to the left, to the right, or up and down. And I think this is, again, a very normal variant. There are some medical conditions that actually result in a very curved penis. So we're talking hook very much to the left or the right or up or down. And this is called Peyronie's disease. This has to do with the formation of scar tissue and plaques within the penis. And it can be somewhat difficult to treat. There's some medical therapies. But really, if it's very, very dysfunctional, then of course there are corrective surgeries as well. So I'm going to bring your attention just to, there's some interest in terms of like surgeries. And the point that I'd like to make is not that there are great surgeries out there that can make your penis bigger. My message is that you should be a little bit skeptical and there should be a bit of concern about purported surgeries to enhance genitalia because the risks are actually quite high. There are a lot of complications. In the majority of cases, they're really not necessary. So there are things that some people buy over the internet, such as extending devices, which stretch the penis, but you have to wear this 4 to 9 hours a day. Like, this is a lot of commitment for maybe a half a centimeter in length advantage. So I'm bringing this up more as a caution as opposed to an endorsement to try and do this type of thing. There are all sorts of other techniques where people are injecting fat or other materials to enhance girth. There's something called phalloplasty, which is a surgery that I perform where you can remove skin and make the penis look longer. And again, the point is, while these surgeries are available, they may not necessarily be the right thing for someone, and I would typically discourage people from looking into surgical genital surgery. So I don't know if you have to answer this question, but often I ask groups, moving on to erections, have you ever tried some of the drugs like Viagra and Cialis? There is a very high prevalence of recreational use of these types of drugs. They're readily available. A lot of people will get a prescription and they'll give it to their friend. And while there's only a mild amount of risk to that, it certainly is much more common that people take these drugs for medical reasons and also recreational reasons. So moving on to erectile dysfunction, which is the main male sexual dysfunction. It's typically defined as the consistent inability to obtain or maintain an erection sufficient for satisfactory intercourse. In other words, it's difficult to get an erection or to keep an erection satisfactory for intercourse. And this definition is actually very narrow, because a lot of people don't necessarily have intercourse. And some people are having same-sex relationships where they don't have intercourse. Some people have other types of sexual relationships where intercourse is not part of their sexual repertoire, and yet they may or may not have erectile dysfunction. So I think sort of these normative definitions of what an erection is or isn't can be challenging because it doesn't apply to everybody, because not everybody has intercourse. The other thing to remember is it has to be sustained for a period of time. So if one night you tried to get an erection and you didn't get it, that doesn't necessarily mean you have erectile dysfunction. You may have had an off night. There are other causes for having poor erections. So it has to be quite persistent. When you look at how common erections are, it's pretty much 50-50. About half of men will say that they don't have erections, and about half of men will say that they do have problems, and the other half say they don't have problems. And it can then be sort of categorized between whether it's mild amount of erectile dysfunction, moderate, or quite severe. And that's like a quarter, a third, and another small amount from that graph. Along with erections, I'm going to come back to the erections, but this whole idea of sexual activity and interest in sex can change over time. A lot of men come in and they report that they're having less interest in sex, what we call libido or desire. Other men come in saying that they no longer get morning erections or nighttime erections, and is this a big deal? And certainly after the age of 40, you see a much higher amount of men reporting both a subjective loss in interest in sex as well as getting those spontaneous erections. So with age, your sexual drive may go down, and that's quite common. And there are a number of reasons for that. It's age, testosterone can go down, things in your family dynamics, your partner also gets older, so a lot of reasons for this. And as I mentioned, it's about half of men will have erectile dysfunction. As you can see here, as you get older every decade, whether it's 40s, 50s, 60s, and so on, the prevalence or how common erectile dysfunction is going to go up and up. So essentially, for men over the age of 60, about half of those men may have erectile dysfunction. So it becomes very common, and of course it can have a detrimental effect to some men in terms of their quality of life in sexual and non-sexual domains. So there are a number of medical conditions. So you always have to think, as a doctor, I have to think, well, if someone comes in with erectile dysfunction, is it a plumbing problem? Are they having poor blood flow into the penis? Or perhaps they have another medical condition. So you can see here that things such as diabetes, which are very common, about 1/4 of men will have erectile dysfunction. Heart disease, very common. In fact, erectile dysfunction can be the early warning sign of heart disease. So many men who will develop a heart attack or a stroke may have had erectile dysfunction 3 to 5 years beforehand, because poor blood flow resulting in poor erections is also indicative of poor blood flow to your heart and your brain. The reason you're seeing it earlier in the penis is that the blood vessels are much smaller, so they're more likely to get blocked up earlier. So erectile dysfunction can actually be very helpful and a wake-up sign for many men to say, hey, I need to take care of this, but maybe there are other parts of my body that need to be addressed. And this really gets into discussions about men's health and really taking care of everybody's health, of course, but a lot of men don't take very good care of their health. And so this could be an impetus to really try and take care of themselves and stop smoking and get in shape, lower their blood pressure, lower their cholesterol, and reverse some of those changes that are taking place. So depression, it's interesting. 90% of men with a high degree of depression had erectile dysfunction. So it's difficult to really say, is this a chicken and egg phenomenon? But certainly men who have erectile dysfunction have higher rates of depression, and vice versa. Lots of men who have depression may also have erectile dysfunction. And it could be because of the mood. It could also be because of some of the treatments that men have for their depression. So antidepressants such as SSRIs, like Paxil and Zoloft and all these drugs that you're familiar with, can inhibit or prevent erections from happening. So what is the impact of erectile dysfunction? I mean, these are some quotes that have been taken, and this is very common. A lot of men come in, and again, it comes back to that first slide of this phallocentric idea that if your penis isn't working, you've somehow lost your manliness or your manhood or your mojo or however you want to describe it. And so people feel that they're less of a man, which is a complete falsehood, of course. But many men internalize a dysfunction of their sexuality as being a reflection of their self-worth, for example. And so it's very common where the impact of erectile dysfunction can have far-reaching effects not only on the man, but also on their relationships with their partners. A lot of partners themselves may feel that they are to blame, that they're no longer attractive or they're not stimulating their partners. It can cause a lot of distress in partnerships, marriages, relationships. Loss of sexual intimacy and closeness can be a result of erectile dysfunction. And it can increase a lot of those psychological negative effects such as depression, anxiety, etc. So definitely it's not just the man who suffers from erectile dysfunction, but his partner potentially as well. Sexual dysfunction is of course common in both men and women, and this idea that if you have sexual dysfunction, it can result in performance anxiety. So one of the most common problems is that if you have some erectile dysfunction, you focus on it. And every time you want to perform sexually, you're worried that you won't be able to. And it becomes almost a self-fulfilling prophecy that the stress of getting an erection actually will prevent you from getting an erection. And so it becomes a very vicious cycle in many ways. So when I see a man for their sexual history, I want to look at several domains of their sexuality. First is their sexual desire, so your interest or your libido or the drive in sex. The second would be ejaculation. Third would be orgasm, and the last would be looking at the relationship. And then erections sort of are related to all of those. So it's not just about getting a firm, hard penis. There are lots of other aspects of male sexuality that are important, and we shouldn't forget the relationship ones and the psychological ones, as well as the biological ones. When we look at erectile dysfunction, we do want to know whether it's been a persistent problem. Did it happen all of a sudden? Was there some sort of inciting event? Are there other types of medical reasons? Sort of describe it. Is it situational? Is it when they're by themselves masturbating? Is it when they're only with partners? Is it only when they're with a new partner? Are they having spontaneous erections? Do they respond to erotic stimuli, etc.? So you have to, at least I have to try and look at when is this occurring. And if you as a man are having problems with your erections, you have to try and deconstruct, is this a problem that's really situational? Is it only when I'm on a first date? Or is it with the same partner I've been with a long time? Or is it only when I drink alcohol or I'm really tired or stressed? There are a lot of different factors that can contribute to it. When you look at actual biological and other causes of erectile dysfunction, we typically divide it into 4 categories. The first would be vascular. So vascular means blood flow, so plumbing. You have to get the blood into the penis and in some ways out of the penis, of course, and that's what an erection is. Neurogenic is nerves. You have to have a nerve signal, an impulse, to also get an erection. Erectile dysfunction can be related to prescription drugs. So other drugs that you take for other medications can have negative effects on your erections. And the last, of course, is psychological or psychosocial issues that can impact erections. This is a penis, and this is a penis cut in half. And this is just to really show that the penis is made of sort of this erectile spongy tissue on the left side and the right side. At the bottom, here's your urethra that you pee through. And these are all sort of connected, and the whole point of an erection is that you have blood flow in, and the blood flow in kind of compresses the outflow, and therefore you get a bit of an imbalance, so the blood tends to stick around in the penis, and therefore it remains engorged. Okay, so there's a bit of a plumbing, and this is going to apply in terms of your knowledge about types of treatments that we give for men, because it all comes down to plumbing in the large majority of men. I know this is a U of T and sometimes a younger audience, and the question is, well, how common is it in like university age individuals, for example? And it's relatively low, so somewhere between 5 to 15% of men between 20 to 40. So not insignificant, but certainly not as common as, say, the 50% of men over the age of 60. Now, I wanted to show you in this slide that middle part here. And yes, there are, inputs from your brain and your spinal cord, but anxiety, depression, obsessive compulsive disorders, phobia, stress, all of these are going to impact sexuality and your ability to achieve an erection. When people have stress and anxiety, they actually release stress hormones, little molecules that are released, something like cortisol, for example. And these hormones that are circulating can actually prevent an erection from occurring. They inhibit an erection. So the more stressed out you are, about getting an erection, you're going to inhibit it. So a lot of this is truly psychological in nature. these are some statistics just showing that erectile dysfunction is common and it goes up in age, and there's always a biological component and a psychological component to it. I get some questions sometimes about related to activities. One of them is bicycle riding, for example. So some very vigorous bike riders may actually cause a little bit of damage to the blood flow to their penis. And so, yes, some studies have shown a correlation between people who ride bicycles a lot and erectile dysfunction. There are certainly special seats that you can buy. They don't put pressure right in the center where the penis is, but that's certainly one of the more common things that people ask me about. Mechanics is compression causing little blockages to the blood vessels. You get occlusion and these focal arterial occlusive diseases. So it's almost like clots and compression of the blood vessels from being compressed by the seat. A lot of medications have side effects. SSRIs, which are antidepressants, are commonly associated with premature ejaculation. So that's another common complaint that men bring up to their doctors. And it may be medicine related, so that's something to bear in mind. Another very common medication that a lot of young men and older men are on is Propecia, which is a hair growing drug. It's called finasteride. So this is a drug that at high doses is actually for your prostate to shrink it down, and at low doses it promotes hair growth. So there are tens of millions of men, honestly, in North America who are taking Propecia, finasteride. But it does relate in some sexual side effects, such as erectile dysfunction, low libido, breast tenderness. And in some of those men, even if you stop the drug, those side effects can persist. So that's one of the risks of taking that drug. It's called post-finasteride syndrome. The other thing is a lot of athletes and people like to take anti-inflammatories like ibuprofen, and these are called NSAIDs, and these are actually associated with a greater than 2 times higher risk of developing erectile dysfunction. The mechanism isn't necessarily clear, but again, some people who take even over-the-counter drugs may be increasing their odds of having erectile dysfunction. There are certain associations or correlations between ED and other lifestyle things. So those who have lower levels of education, psychosocial problems, people with less sexual experience, and also those who use drugs and smoke are more likely to have erectile dysfunction. Things like alcohol, sedentary lifestyle, obesity, depression, in the young men, not older men, but young men, are less likely to be associated with ED. So what are some things that younger men and any man can do to help with their erections? Certainly behavioral modifications are some of the best things you can do before we move on to medications or actual treatments. Weight loss is very good. Losing even 10 pounds can improve your erections, your energy, improve your urinary symptoms if you have an enlarged prostate, for example. So exercise goes along with weight loss, stopping smoking and recreational drugs, and taking a look at the drugs that you actually do take, because they may have some side effects. PDE5 inhibitors, that's the class of drugs that are Viagra and Cialis and Levitra. So these are pills that you take that promote erections. And what's really kind of nice about these medications is that regardless of the cause of your erectile dysfunction, you could try taking one of these medications. So if your erectile dysfunction is because of poor blood flow from cardiovascular disease or erectile dysfunction or depression, these drugs tend to work quite well regardless. So that's quite nice. So again, I think I would emphasize that paying special attention to the psychological aspects of sexuality and sexual dysfunction is really important. The answer most of the time is not in a little blue pill. Okay? You really have to try and think about all of the causes, because sexuality is not just in a penis or a vagina, it's in our brains, in our bodies, and in our relationships. And so, listen, I'm a surgeon up here telling you that you should pay attention to your psychological well-being and your relationships. So I think it's really important. That being said, the pills do work. And even if you have erectile dysfunction related to psychological causes, if you do take a pill, it can dramatically improve your erections compared to taking a placebo. So in some instances, while you're working through some of the psychological causes for your erectile dysfunction, a pill might help you gain some confidence and get your function back. You can keep your relationship intact, maintain intimacy, and work through those other issues. So there is a role for that. As I mentioned, there's quite a bit of recreational use of these types of drugs. It's become much more popular. There's a lot of reasons why someone might want to try it. What's interesting is that the main advantage to taking one of these types of drugs in young, healthy men who do not have erectile dysfunction is a shorter refractory period. So that means the time from when you finish having sex and you have an orgasm until you can have your next erection becomes shorter. But it actually doesn't help with how good your erections are, stronger, longer lasting. It's the same as placebo. I would issue some caution. A lot of people get drugs, these types of drugs, so Viagra, Cialis, etc., from the internet or from friends or mail order, and I would just say that you should be cautious. You don't know what you're getting from not a pharmacy. There are a lot of counterfeit drugs. You don't know what sort of chemicals they put inside them. There could be some potentially dangerous interactions with other medicines you take. Typically, a lot of these drugs are counterfeit, and they have a very small amount of the actual drug inside it. So about 10% of all of these drugs around the world are actually counterfeit. And if you look at how much of the active ingredient is inside, it could be anywhere from things like 30 to 50%. So very low amounts. So even if you think you're paying to get the drug, you're probably getting only a fraction of it. So it's a waste of your money and an increased risk to yourself. So I get a lot of referrals from family doctors or men seeking treatment for their sexual dysfunction, particularly erectile dysfunction. And they often ask, besides pills, what else is there? So historically, before actually the pills came around, there actually used to be liquid medicine that was a vasodilator, brings blood into your penis, and you would have to inject it into your penis with a small needle. And it doesn't sound very appealing, but it actually works quite well. And we still do this type of treatment for men who don't respond to the pills. Over the last decade or so, there have been some newer technologies that have come out that have actually been designed to treat the underlying cause of erectile dysfunction. So when you take a pill, it lasts only for a certain period of time, a few hours, right? So 6 hours, 8 hours, etc. But it's not actually going to change the underlying problem of your erectile dysfunction. So I was asked to sort of highlight some of the new technologies that are available to treat ED. So one that's become quite popular is something called low-intensity shockwave therapy, or acoustic wave therapy, or sound wave therapy. And the idea is that current medications have their limitations. You have to take them about an hour before intercourse, 2 hours after you last ate. So there's a bit of a timing issue, and you sort of lose that sense of spontaneity. And also, you're dependent on the treatment. You don't take it just once or twice. Every time you want to enhance your erection, you take the drug. So there's sort of this interest in, well, what if we could reverse some of the underlying causes of erectile dysfunction? So they looked at sound waves or shock waves, and this is exactly what you would think of if you saw a plane flying really fast beyond the sound barrier. It makes that big sonic boom. That's a shock wave. And in medicine, we've been using shock waves for a number of things. If you've ever heard of someone having a kidney stone, they can actually break it up with sound waves. We have one of those machines at St. Mike's, for example. And they've been using it in sports medicine in sort of joints to help regenerate cartilage and tissue and blood supply. And then further to that, they're actually using it in diabetes and heart disease to try and promote blood flow. So of course now they've started to apply it to the penis for erectile dysfunction. And what shock waves do is they cause new blood vessels to grow or sprout in the penis. So if you think of that picture I showed you with the blood supply and the arteries and veins going in and out of the penis, the majority of time erectile dysfunction is a plumbing problem, right? Not enough blood flow going in and out. So if we can actually, in some ways, turn back the clock to a time when you were younger and you had better blood flow and better arteries and they weren't clogged up, then you could potentially get better erections. So there's a treatment where you come in for a series of treatments, so twice a week for 30 minutes, and you apply, it almost looks like a big microphone to the penis, and it gives these sort of painless sound waves. They're completely painless sound waves to the penis in various areas. And what it's doing is that it's causing those new blood vessels to grow and regenerate in the penis, thus improve blood flow. So it's been studied in a number of very reputable scientific journals that are sort of randomized trials. And you can see here on the left-hand side of the screen that if you look at total number of erections, the time of the erection, the rigidity, etc., the responses are quite good. It's somewhere between 65 to 70+% of men will get significant improvements in their symptoms. And there's always this question of, well, is it a placebo effect? So they actually were very clever. They measured the blood flow in the penis and they measured the blood flow in the arm. And they showed no changes to the blood flow in the arm, but big changes in the blood flow to the penis. So it really does cause these new blood vessels to grow. This is one study where they took men, none of whom could have an erection before the treatment. And you can see here that the red group here, which is close to 70% of those men after treatment were able to have an erection firm enough for penetration. So it really does work quite well compared to placebo. This is a group of men who have such bad erectile dysfunction that even if you gave them a Viagra, it wouldn't work. And they took those men who were sort of the most severe cases, and again, about the same percentage, around 72% of those men who could not have an erection were later able to have an erection when they took a pill. So they were able to improve their function from non-responders to pills to responders. So this is, what's kind of exciting in the 21st century now is we're actually having new technologies and treatments that we didn't have before that can actually treat the underlying blood flow issue as opposed to just taking a pill. So again, those numbers are around 72% of men will improve even if they didn't respond to pills historically. And even if you follow them out for 1 year and 2 years, the effect is still relatively well sustained. About 75% of those men will still keep their erections. This has been studied now. The numbers are much higher than the 300 I have in this slightly older slide. There's been randomized trials over the world. And again, I think this idea of about a 65 to 70% success rate is really quite good. And as a result of that, this is now sort of being adopted and recommended in a lot of guidelines. So if you go to Europe or America and you have this type of problem, you can certainly try the pills and you can also try sound wave therapy. Another big question that people ask me about relates to premature ejaculation. I would say that this is a very common male disorder, the definition is really subjective. Is it ejaculation within 1 minute, 3 minutes? Some people say, I have sex for 30 minutes and then I ejaculate, and that's too soon. So everybody's sort of subjective interpretation of what premature is varies. There are definitely both psychological causes as well as biological or organic. Typically, the best treatments are actually psychological treatments. So you can do exercises where you can train yourself to get a little bit more attuned to the sensation that you're going to have an ejaculation and learn to sort of sustain that or inhibit it. So those are techniques like stop-start or squeeze technique, etc. And last, if it's really necessary, is that you can actually take a medication which will prolong ejaculating. So it sort of delays it, but then you may be having the side effects of taking this drug anyway. So that is the majority of my talk. I wanted to sort of just give you a whirlwind overview. There are lots of other areas regarding male sexual health. And I'd be happy to open it up. I mean, male sexual health is both for heterosexual and homosexual relationships, young men, older men. There is certainly a great deal of psychological components as well as biological components. There are a lot of great treatments available, both sort of medical as well as some of the newer technologies. I think it's really important to think about the dysfunction and see how it affects you and your partners. See if there's other medical causes, such as other drugs you're taking or medical conditions. I think it's very important to bring it up with your family doctor as the first point of contact, and then be referred appropriately. I think that if people sort of suffer in silence, like many people do with a variety of conditions, then they'll never get better. And a lot of them don't even know that they could get better. So I'm quite happy to discuss any questions you have. I'll try my best to answer them on any topic related to sexual health. This is my website for my clinic that has some information on both conditions as well as a variety of treatments that we offer. I'll take it from there.
What are the latest developments in detecting prostate cancer?
It's a great question, so I'll just repeat it for the audience. What are the developments in detecting prostate cancer? So the prostate is sort of by definition a sexual organ. You don't need it for erections, but it contributes to sort of semen and ejaculate and sperm health. But so if you're not trying to have kids, you really don't need your prostate. Prostate cancer is the most common cancer amongst men, aside from like skin cancers, right? So it's the most common, just like breast is for women. We typically recommend that men get screened for prostate cancer at least around the age of 50, just to get a baseline. And of course, if your PSA, which is a blood test, is very low, then you probably don't have to have very rigorous screening. It's a conversation you can have with your doctor. In terms of new technologies or treatments, there are a number of new tests that are available that my clinic actually offers. So there's something called a PCA3 test, which is a urine test now that looks for molecular markers in cancer cells. So men can come in, have their prostate examined, then give a urine sample, and we send it to a special lab, I think it's in Texas, and it comes back with a risk score of probability of having cancer. There's something else called the 4K test, which again is a brand new test from the States that we now have at our clinic. And again, it just gives you a little bit better sensitivity in terms of detecting prostate cancer. But the general way of detecting prostate cancer is to get your prostate checked, which is a rectal examination, a finger in the bum, to feel the prostate, feeling for lumps and bumps, and a blood test for the PSA. And what you're looking for in the blood test is a series of rises in the PSA over time, over a discrete period of time. So a single test isn't all that informative. You really want to follow the trend over time and see by how much it is rising, the trajectory. Follow-up question?
Yes.
Yes.
So would you initiate that, ideally, would you initiate it earlier? A PSA test to establish a baseline earlier than 50, or?
We recommend 50 as the baseline unless you have a first-degree relative, like a brother or dad, who got prostate cancer really young, and you might want to get yourself checked around their age or 5 years below. If you're of African ancestry, like African Canadian, we recommend usually a little bit earlier, like 45, to get a baseline, because the risk amongst black men is higher. Yes? It's a good question. So how do you prevent prostate cancer? We don't know. I mean, we think some of it is certainly genetic. You can't prevent your genes. You're born with them. Some of it may be dietary. So there's been some evidence looking at inflammation in the prostate and inflammatory things in your diet. So red meats, things that are carcinogenic, barbecued meats and red meats that you eat in your teens and 20s may relate or translate into prostate cancers later on. There's been some autopsy studies that show that even in young men, 20s and 30s, they may show pre-cancer in their prostates. So it's something that develops earlier in life, but really only manifests itself and is important to find sort of in the second half of men's lives. So there's no great early treatment that we're recommending. I think a healthy diet, not being obese, not smoking, not eating too many red meats is probably good for your overall health, and it's probably good for prostate and other cancer prevention. Sir?
So, first of all, I learned stuff here that I didn't know before, just about mechanics and about, I never even thought about like what makes up a penis, what's in it. Maybe a few blood vessels, I didn't know what else. I'm still not sure I really know, but now I want to know.
Yeah.
So I've got 3 questions. The first relates to the last one. Why don't, if all you really need it for is procreating, why don't you just take it out when you're finished or you're not wanting a prostate?
So the question is, why don't we just take out prostates when you get to 50? Pretty much, right? So there are risks. There are risks to removing prostates. First of all, our healthcare system would not be able to take out the prostate of every man, right? Also, we would be treating too many men, because the chance of having prostate cancer in your lifetime is about 1 in 6 and 1 in 7. 1 in 6 or 1 in 7. So that means 5 out of 6 don't need their prostate removed. So that's clearly not a good risk-benefit surgery. It would be expensive for a system, and more importantly, too many men would undergo unnecessary surgery that has significant side effects. So for example, the biggest side effects of having your prostate removed or radiated is erectile dysfunction and urinary incontinence, meaning leakage. So many men who are treated for prostate cancer can no longer get an erection and leak urine. So that's why the idea is we have to try and identify the men who have prostate cancer, then those who don't, and then identify the ones who will actually be harmed from their cancers. Because there are a great number of cancers that will be very slow growing and will never hurt you, and we leave those ones alone.
I've got 2 more questions.
Sure.
if you don't mind.
I'm here.
Are you seeing an increased number of, well, this may not be an easy question to answer, so I'll ask it differently. When people come to see you, are they able to speak more freely, more recently than they were in the past? And because of the context of this talk, do you have any ideas as to why, if they're not able to speak freely, that's the case?
Right. I think that there's definitely been an evolution on our discussion about sexuality over the last 20, 30 years in North America. I think the introduction of pills like Viagra and Cialis really opened up the conversation. So those drugs have been out for about 20 years. And before, it really was taboo. Like really no one talked about erectile dysfunction. And then this little blue pill came along, and all of a sudden you had celebrities and Bob Dole and all these people who were endorsing admitting they had erectile dysfunction and using it. So I think there's definitely been an evolution in terms of a greater acceptance of this as being something that you can talk about with your doctor, talk about it in public and with colleagues and friends. What are some of the reasons why people are hesitant to still bring it up? So I think misinformation is one, that they either don't understand the condition, they don't understand the treatments, they put the blame on something which is not correct. It's their fault, it's their partner's fault, it's society's fault. I think there are still many cultures that may be a little bit repressive or not as sexually open, and that's no judgment on them. But if someone comes from another culture and they come to, say, U of T to study for the first time and they're 19 or 20 years old, they'll often get referred to me and they just really don't have any sexual experience or knowledge of sexuality, and they come in with complaints that are really common, that are seen amongst a lot of people.
Last question.
Sure.
You talked about how in many cases it could be erectile dysfunction that causes depression, causes a sense of lack of worth in some men. And the question is, on a very long historical scale, wouldn't it be the case that men are really anxious to procreate in the way that men procreate? And wouldn't that be a reason to say, yeah, maybe you're not fulfilling those purposes anymore, and in that respect, oh, you're not as much a man. And on the flip side, and this is more controversial probably, wouldn't it be the cause for people saying boys will be boys, and that kind of behavioral thing that develops out of that same historical?
Right. I think from sort of a bioanthropologic perspective, I think that's a real term. I mean, the idea that men have to procreate, and it's sort of the core of their primitive being. A core, yeah. Then, I mean, I definitely think that it could be interpreted that way. And in fact, some people would argue that premature ejaculation is evolutionarily adaptive. If you can partner and ejaculate as quickly as possible, then you're more likely to inseminate your partner and pass on your genes, right? That's the biological imperative. Yeah. So this idea that, and again, very primitively speaking, this does ring true. Sort of the idea of the penis being centric to biologically what many of men are programmed to do.
And the last part of the question also.
About, remind me? Boys will be boys? I don't know if I'm in a position to answer the whole boys will be boys thing. I mean, I think that from a societal perspective, there are certain expectations put on boys and men. I don't think that that's necessarily hardwired. I think I have two young boys, and I'm sure that they behave very differently than two young girls. I don't know if it's an excuse for bad behavior, but I'm sure certain behaviors are genetically influenced. How's that for an answer? Okay. A question over here, and I'll move around.
An age-related incidence of ED. I haven't seen anything about testosterone levels, and that was brought up. So, has there been any studies on the age as testosterone drops in the frequency of ED?
Yeah. So there's a definite relationship. I have lots of slides on testosterone. I don't want to bore you, but there's a relationship between testosterone, which is the male hormone, and erectile function or dysfunction. So you need to have enough testosterone to get certainly the desire. Testosterone is the main drive, both for men and women. Women have small amounts of testosterone as well. And that is largely important for their sexual drive too. So men's levels of testosterone tend to decline even from their mid-20s. And it's much more of a precipitous drop as you get to sort of your 40s, 50s, 60s, but there is definitely a decline initially of testosterone in young men. And there may be a relationship. Typically, testosterone levels have to be very low. So there's a normal range, and you have to be on the low end of normal to really be having fairly pronounced erectile dysfunction. But even some low levels of testosterone that you would consider normal from a laboratory perspective may result in erectile dysfunction. So one of the things that we would look into if you came in with erectile dysfunction is we could potentially look at your testosterone. But often it's not just poor erections. It's decreased interest or libido, but it's mood changes. So you have fatigue, difficulty concentrating, loss of energy. You can be more irritable, more quick to anger, loss of muscle mass, increased fat. So there are lots of other behavioral changes and physical changes that can occur with a low testosterone as well.
And do testosterone supplements as sold in Canada, do they directly replace that level, or does the body break that down and then we get a minimal effect?
So prescription testosterone from a doctor will replace the low testosterone. By taking external testosterone, it will shut down your body's ability to make natural testosterone. So one of the concerns for young men who are taking steroids at the gym is that they are messing with their hormones and they are shutting down their body's natural ability. So their testicles will shrink. And when they one day stop taking the steroids, when they're finished their weightlifting years, they may have low testosterone for the rest of their lives because they've permanently damaged their own ability to produce testosterone. So there's a concern. Now, if you're an older person and you have truly laboratory confirmed low testosterone and you're symptomatic, you feel crummy, poor concentration, low libido, erectile dysfunction, then you could be supplemented with testosterone and it will bring you from a low level to a normal level.
So there was no contraindication if you already have a very low level of something. Outside of the normal zone, your body's not going to produce it more 5 years from now.
Correct.
So you might as well, then you would recommend.
I would recommend taking it. There are a number of harms of living with a low testosterone. And so what you're doing is you're not supplementing your testosterone so that it's at superhuman, steroid athlete levels. The whole idea is to bring someone from low to normal. And being normal is good. And it's protective. So they've done studies where they look at men who had a bunch of heart attacks and men who didn't, and they found that the men who had heart attacks were more likely to have low testosterone. So there may be a cardioprotective aspect to testosterone. When they look at men who die from prostate cancer, more men die from prostate cancer who had low testosterone than who had normal testosterone. So having a normal testosterone may be protective against prostate cancer, in fact. So testosterone does, in some ways, play an important role in our men's overall health, metabolic health. You're more likely to get diabetes and metabolic syndrome if your testosterone is low, and vice versa. If you can raise your testosterone, you're more likely to correct your blood sugars and be able to exercise and get in shape. So there's a direct relationship between your hormones and insulin and diabetes and testosterone as well. Yes?
If premature ejaculation is an evolved adaptation, and that begs the question of why would we call it premature?
Well, again, I think I'm speaking definitely from an evolutionary perspective. I think the idea of premature ejaculation is it's defined as a short period of time from essentially penetration to orgasm. It's anywhere from 60 seconds to 3 minutes is what would be defined as premature ejaculation if you look at sort of scientific literature. But again, this is sort of it's a definition that someone came up with. So it does relate to the reuptake of serotonin and dopamine in your brain. Okay? So SSRIs are serotonin reuptake inhibitors, right? Selective serotonin reuptake inhibitors. And the idea is that the pleasure centers of our body rely on serotonin and dopamine. And if you are depressed, it's down. And sexuality, you get releases of endorphins and these types of things. So by modifying serotonin and dopamine, it results in a prolongation of being able to achieve an orgasm. I don't know if that's a great answer. It's a little bit more into the pharmacology that I'm not super familiar with, but
I would think it would be the other way around, but it's interesting to me.
yeah.
We haven't spoken about HPV. Maybe make some comments about that.
Sure. So sexually transmitted illnesses, we used to call them STDs, and I call them STIs. So HPV is herpes, right? And there's a number of different types of sexually transmitted illnesses. They could be oral, they could be genital. There's been some press about rates of chlamydia and gonorrhea going up in Ontario, particularly amongst men who have sex with other men. And this is a reflection of our times. People are much more comfortable with the ideas of transmission of HIV and AIDS, and maybe people have become a little bit more lax in terms of using barrier contraception like condoms. So I don't know what to say except HPV is a concern. Some types of genital warts, for example, like condylomas, can eventually turn into some types of skin cancers. So, if you have it, it's probably good to get it checked out and treated. You should be cautious if you're with new sexual partners, or disclose it, or use a condom. And that's sort of my experience with STIs.
Was there any reason to not give it to men at any particular time?
Is there a reason to
To not give whatever the medication is for HPV?
vaccine? Like the one you give in childhood?
Are you asking about human papilloma vaccine
Yes.
or herpes simplex vaccine? Human papilloma. Okay, so that's like the
For a number of
So-
years, it's only been given to girls.
Yeah, so the risk is that girls who get HPV get cervical cancer, and it's lethal. For boys, the idea is if you get a genital lesion, you could transmit it to a woman who could get cervical cancer and die. The rates of male cancers are much less. You could get a penile cancer, particularly in men who are uncircumcised. But again, it's not my, this is sort of like in the realm of pediatrics and infectious diseases. So I don't have an opinion one way or the other in terms of whether young boys should get vaccinated. I mean, I'm in favor of vaccines. I think vaccines are great. So if you could do anything to prevent your risk of getting or transmitting a disease later in life, then I would be for it. That's my personal opinion. Sir?
What's your take on endocrine disruptors and estrogen mimickers that are leached in from the plastics that our food is processed in, and the other elements in the food sources that now have those derivatives?
So I'm really not familiar with this area. I've sort of heard it in sort of the general press about the risks of certain types of chemicals that are, as you said, leached or you get from like plastics and PVCs and BPA, yeah. So I don't know. I mean, I think they've done some population studies looking at birth defects and estrogenization in utero, but I'm really not an expert in that area.
But if you're in turn placing within the nutrition supply chemicals that disrupt the production of testosterone and encourage the production of estrogen, then a lot of the questions that a lot of the things you just presented would be resolved around that fact on a scale that might be brought across the board. So as a men's health issue, just as a societal health issue, because not only does it affect men, but it hyperfeminization of women as well. It causes ovarian cysts, et cetera, et cetera. So it's a dual issue that affects both sides.
Yeah, I mean, I from my understanding, again, I think it's a major public health concern. As we rely more upon processed foods and the containers that they are delivered in, we increase our risks of being exposed to these types of chemicals and byproducts. So I think it's a major issue, one that I'm certainly not an expert in, but I think it's very valid that a group like this would raise it for sure. Good, very good comment. Oh, I haven't heard from you, and then I'll come back to the back. Please.
How common is HIV in hetero men, and can heterosex transmit HIV?
So I'm not familiar with the rates of HIV amongst heterosexual men. Someone in the back?
8 in Canada. There are only 8 men who are heterosexual of HIV in Canada.
Sorry?
There are only 8 men in Canada.
Who sexually transmitted from a heterosexual encounter?
From what I know, yes.
So, listen, I think the risk is there. I'm not quite sure what the number is in terms of heterosexual risk. It still exists. I think it's a lower risk than those in men who have sex with men relationships, but it's certainly possible. Like biologically, it's possible. Yeah. Yeah, but there could be tears in mucosa. There could be micro abrasions. It's quite low, but again, I would advocate that the use of safe sex, like with a condom, will reduce your risk.
We'll have time for one last question.
I haven't heard from you. Yes.
Is there a relationship between periodic leakage and prostate issues?
Periodic urine leakage?
No, urine leakage.
Urine leakage?
Periodic.
I mean, the short answer is yes. It's a little bit more complicated. If you have an enlarged prostate, it could result in bladder dysfunction. If your bladder becomes dysfunctional, you may not empty it all the way, and you may have incontinence, or your bladder may become overactive, and it could squeeze, resulting in leakage. So the very simple answer is yes. I mean, there could be a relationship between prostate problem and a bladder problem and some leakage, but it's not necessarily like a linear relationship. Yeah, it's a little bit around.
Okay. We will
She's the boss.
the question and answer period, and I understand that Orest, who also facilitated this talk tonight, he has some remarks for us.
Well, I think it's, we've had a good session and good questions and answers, so thank you very much to the Canadian Centre for Men and Families and also to the U of T Men's Issues Awareness Society for hosting us here tonight. I want to thank Dr. Elterman for taking time out of his very busy schedule to come and share his thoughts with us tonight. And so I'm with a company that helps clinics establish a new form of therapy that Dr. Elterman referred to in his talk. So it's the low intensity acoustic sound wave treatment for erectile dysfunction and he did share some of his data. It's been now extensively studied over almost 10 years, and we've had several clinics in the Greater Toronto area. There are actually 6 clinics that offer the treatment, and there are some brochures just on the table up there. So I'm not going to talk to you all about its role in the treatment of erectile dysfunction, because Dr. Elterman covered the evidence-based data as a part of his talk today. But if you'd like more information, there are brochures on the table. There's a website and a list of clinics where you can seek out help if you or anyone you know needs help in that part of their lives. So I'll leave it at that. I just want to thank you all for this great initiative and for inviting us here today. Thank you.
Well, thank you for facilitating, and I just want to thank Dr. Elterman for coming to the UTMIAS and for speaking tonight. On your way out, I welcome you to browse our materials on the side here. There's some from our sponsors tonight, and I hope to see you back next month at our talk.